Hi, good afternoon. On behalf of the Pain Society of Alberta, I'd like to welcome you to our Lunch and Learn today. Thanks for joining us. I'm Diane Roylance, and I'll be your moderator today. And thanks for taking this time out of your hectic schedule. So hopefully you can get some calories in while we go through this great session. Now, before we get started with our speaker and while everyone's settling in, I'd just like to remind you to go up into the right upper corner of your screen and locate that speech bubble that you'll see. If you just hover over that, that'll allow you to join into the chat box so you can be part of the ongoing conversation throughout our session. And as a reminder as well, all of the questions for our presenter will be emailed, please, to question@painab.ca. So all your questions will go there, and you will have access to that email address ongoing throughout. So if you didn't jot it down, don't worry too much about that. So as you all get organized, I'd like to acknowledge today that I'm joining from the banks of the Bow River in Calgary. And in the spirit of us gathering today to work on healing, I'd like to recognize the peoples, the healers, and all those who have passed through this territory of Treaty 7 and the Métis Region 3. And in the spirit of reconciliation, I'd like to honor the peoples, their lands, and I strive to listen. Now, moving to the good stuff here from our very esteemed person that we have today speaking. I'd like to introduce Dr. Ameya Bopardikar. Ameya did his undergraduate at McMaster University, Ontario, and carried on to do his medical degree at the University of Toronto. And Ameya completed his residency in anesthesia at U of T, followed by a fellowship in chronic pain at St. Michael's Hospital in Toronto, which is one of the leading areas of pain research and teaching in the country. And Ameya now practices both as an anesthesiologist at the Foothills Medical Center here in Calgary and as a chronic pain physician at the Calgary Chronic Pain Center. So he's a busy human, so we're grateful to have his time today. Ameya is passionate about educating, especially medical students and residents, through the University of Calgary. And I think a sign of his dedication and his skill is the fact that he's been awarded an excellence in medical education from the U of C. So congrats on that. And I think you'll see that reflected today in the talk. So the Pain Society of Alberta is honored to have Ameya on our board of directors now. We managed to recruit him, which is cool. And also he's helping assist with our Alberta Pain Education Collaborative. So without further ado, I will welcome you, Ameya, and please enjoy the session today. I'll see you again later for the questions.
Thank you for that wonderful introduction there. My name is Ameya Bopardikar. I am certainly, as Diane so kindly described me, an anesthesiologist by training, but primarily also a multidisciplinary chronic pain physician. Certainly what that implies is it's not a one-man show by any means. And as you can imagine, in chronic pain, this is something that a role that I share very closely with both nurses, social workers, physiotherapists, occupational therapists, pharmacists, dietitians. So truly an undertaking of multiple folks taking care of groups of patients. And finally, I'm also an interventionalist in chronic pain. So I do manage folks with interventional management, and hopefully I'll be able to speak to some of that in a meaningful way. Moving on, firstly, I just want to address any disclaimers. I have no conflict of interest to share. Specifically, I'm not getting any support from any sources that would conflict my thoughts here. Number two really is the state of evidence, and this is the major challenge in pain that we all face. Our patient groups are heterogeneous. The ways to measure and understand how these folks respond to therapies and treatments is extremely challenging and very limited, and certainly makes extrapolating the entirety of management of these patients very difficult. And so I do want to kind of state that at the outset, but hopefully still provide you with some pros and intervention and thoughts around managing your clients and patients in the community. Finally, I want to make it clear, as Diane identified, I work at the Chronic Pain Center in Calgary, it sometimes does feel a bit like an ivory tower. So I can't necessarily be an expert in your practice, and certainly the development of low back pain and chronic low back pain in the community is by majority seen by practitioners in the community and managed solely by practitioners in the community. So certainly I'm happy to receive your questions and understand your challenges as we get to the end of the conversation, and hopefully provide some pearls around what you face. So let's talk about some of the objectives of the talk today. So firstly, we talked about categorizing the different causes for chronic low back pain, both through history and physical examination. Utilizing the peer guidelines, so these were recently put out by the College of Family Physicians, along with Alberta in the community, to access multidisciplinary care. And really what I mean by all this is, how can I figure out what my patient has? What medications and doses should I be starting with? How do I engage healthcare providers and allied health providers? And finally, what should my patients expect? So what do I actually tell them so that I can educate my clients, my patients in a meaningful way? What do I tick off on that requisition form? This really speaks to partly the Alberta advantage in terms of what we have access to in the community, and I'll touch on that near the end of my talk. And finally, how do I avoid the growing wait lists of accessing comprehensive multidisciplinary care? And I'm certainly aware of what I face when I see patients and clients referred into our site. And know how many challenges care providers in the community deal with. So I'm actually going to start this conversation in a completely backwards way. I'm going to start with the pearls for a couple of reasons. I'm sure sometimes people will get pulled away, and I want to make sure you get the bulk of the talk right at the beginning, but also to hopefully highlight some of the complexities and nuances we have in low back pain management. Low back conditions may not be related to the extent of anatomical derangement in the back. And this really starts to speak to the idea of, clients and patients wanting imaging and really wanting to understand exactly what the problem is anatomically so that they can apply a biological model to what's going on. It certainly is not that simple. And I encourage clinicians to trust their clinical picture, their physical examination, what they think may be going on, and not necessarily relying on the imaging. Imaging is helpful, but certainly not the be-all, end-all, and certainly not the diagnostic tool that we should be using with managing these patients. Rarely is it related to a life or limb-threatening problem. That said, I recognize that most of the clients or patients you deal with that have severe or consistent low back pain certainly find that they have quite a lot of limitations to their quality of life. There are often multiple pain generators. It's almost never just one problem. Finally, it's extremely important as you manage these patients chronically that you focus on tracking function and not pain. Firstly, we don't have great ways to measure pain at all. The 1 to 10, 10 being the worst pain you've ever had, is not a particularly useful tool as we chronically manage these folks. Going on, really, functional-based rehabilitation is really the cornerstone of managing chronic low back pain. This can include CBT or cognitive behavioral therapy. It certainly can include comprehensive multidisciplinary management, but I recognize how tricky that can be to access. And finally, and this is often a question that I deal with, and certainly patients, and I'm sure care providers like yourselves would deal with, is patients wanting surgery. It's surprisingly rarely indicated. The evidence also would suggest that it's typically non-inferior or even sometimes inferior to functional rehabilitation. And I'll touch a little bit on that because I know that's something that you face regularly. So let's just step back for a second here. What is chronic low back pain, just simply described? We think of back pain in both acute, subacute, and finally chronic phases. Chronic phases imply that it's been going on for at least 3 months or so. And kind of the accepted definition, especially from kind of the European guidelines and also from the American Pain Society, would be around pain and discomfort localizing below the costal margin and above the inferior gluteal folds. And it can include or exclude leg pain. It's extremely common between working age folks, so people between 25 and 64, often has a dominance towards men over women. And there typically is a very high lifetime prevalence. You will see at least 83.8% of folks reporting at least having one episode of back pain in their lifetime, which is extremely high. When we look at kind of the local experience, so when we look at major surveys undertaken in both Alberta and Saskatchewan, at least 40% of these patients will show up and see a provider of some sort. This could be their family doctor, certainly could be their physiotherapist, a chiropractor, even an occupational therapist, sometimes a massage therapist. A majority of these patients do see primarily their family doctor, about 65% of patients. And interestingly, about 65% of them will remain solely managed by that primary care provider. So it's extremely important that this is a disease that is managed in the community, and we find ways to do that well. Often of the high lifetime prevalence, typically 24 to 80%, as reported in the literature, will develop a recurrence. So the burden of the disease is extremely high, and the management of this disease continues to remain primarily in the primary care home, so in the community. The major things that we always think about, with chronic low back pain are the red flags. And these are important to understand simply because it acutely changes management. And I won't belabor this issue, but really the major concerns are, is there a concern for fracture? And that could be related to a high-speed injury, or if these patients have moderate injuries with significant risk factors, things like elderly patients, high corticosteroid use, osteoporosis. Concerns for cauda syndrome with fecal incontinence or urinary retention with saddle anesthesia is a major concern. If you're finding that your patient is describing symptoms consistent with myelopathy, with global progressive motor loss, they have evidence of really hyperreflexic, with clonus, gait disturbances, reduced fine motor control, and telling you things like they can't hold their coffee cup in the morning. They're having trouble eating food because their fingers don't seem to work properly. These are things that we should be really concerned about. Infection with things like meningitis or malignancy related to, unexplained night sweats, weight loss, and finally things like abdominal pain that could be perpetrating as back pain. With sudden pain that shows up with features that are not consistent. They're faint, or they're not really getting worse with any kind of spinal movement. So these are flags that we have to kind of consider with any chronic low back pain patient. We have to address these more immediately and urgently. But moving on, there's kind of four major patterns we look at with back pain. What's interesting is, I'm sure you guys have experienced in your practices that nobody fits so discreetly into a pattern, but it's nice to understand these patterns so we can kind of identify if patients have any kind of overlap, and hopefully identify some treatment or tools that we can use for treatment. When it comes to pattern one, typically these patients describe pain that's worse in their back, buttocks, groin. Sometimes it radiates down to their legs, and almost never or rarely below their knees. They describe the pain to be either constant or can be intermittent as well. Worse typically on flexion, and certainly improved with extension. They often have a normal neurological examination with normal power in the lower extremities, normal straight leg raise tests. However, they may have possibly abnormal Faber or flexion abduction external rotation testing of the SI joint. So these are certainly, this pattern kind of typically fits with a discogenic type picture, facetogenic type picture, myofascial pain syndromes, sacroiliac joint pain. So these are kind of pattern one kind of diagnoses. You'll notice that the diagnoses tend to overlap. So many diagnoses can have similar sort of different pattern phenotypes. Moving on, pattern two. Typically, these patients identify pain that is worse in their back, buttocks, their groin, and may radiate to their legs. It's, again, almost never below the knees. This pain tends to be typically more intermittent, and it's worse with extension and eased with things like sitting or flexion. Often these patients have ipsilateral pain on lateral flexion, so as they move to one side, the pain stays on that side. often a normal neurological exam, a normal straight leg raise test, and often paraspinal pain on deep palpation. These patients I would consider to have, either facetogenic pain syndromes, myofascial pain syndromes, things like cluneal nerve entrapment, and these are often patients that have back-dominant back pain. Moving on to pattern 3, these patients typically describe pain in their legs. It can also be in their back, but tends to be leg dominant. If you were to ask them things like, if I had a magic wand and I could take away one pain, which one would it be? Often they will choose that it's the leg that they would want to have be resolved. This pain can be constant and often is worse or exacerbated by sitting or flexion. Certain movements can also trigger pain like rotation, and they often describe this pain to be like electrical shocks. The pain may lessen with specific positions, but certainly may not go away completely. These patients almost always have positive neurological findings, dermatomal distribution of pain or paresthesias, and they will often have a positive straight leg raise test. Now, these patients kind of fit within that classic slip disc nomenclature that patients would describe. So I would describe these patients as having radiculopathy, or they may also have specific peripheral nerve entrapment syndromes like piriformis syndrome, or more diffuse degenerative disc disease that causes some sort of obstruction of the nerves as they're exiting the spinal canal. Now, finally, we look at kind of a pattern 4, which is a bit of a unique pattern. Often these folks have pain that's worse in their leg and often could be related to heaviness or aching. The pain tends to be intermittent. If it's, things that could be worse on flexion, often improved with extension. However, there is a subtype in this group where they describe that their pain is improved with flexion. And often that group we describe as neurogenic claudication, and that almost always specifically fits into someone who may have severe spinal stenosis. The folks that tend to improve with extension with worse on flexion often have degenerative disc disease. So these are the kind of patterns we typically think of when we work with pain. And, shortly I'm going to tell you why none of this all really matters. But part of that is, if they were all that simple, if we could characterize patients in a snap like that, it'd be easy to identify what their problems are and how we treat them. Now, rarely do patients kind of converge to such a simple diagnosis when it comes to chronic low back pain. And therefore, I think the guidelines now really identify that we should be thinking of low back pain in a slightly different way and more on a treatment basis. So let me get into that a little bit more now. So the treatments really start to revolve primarily around what are described more recently as the PEER guidelines. These were guidelines that were put out most recently, and they were identifying management options for folks who had both osteoporosis or osteoarthritis related pain, low back pain, and neuropathic pain. I've kind of simplified it onto this slide to stick to both chronic low back pain and neuropathic pain, because often the neuropathic pain tends to go hand in hand with low back pain. The foundation of treatment for both of these interventions, both of these conditions, continues to be physical activity. There's extremely good quality evidence that suggests that physical therapy and a functional focused rehabilitation program is actually the way we that we treat this problem. Often adding on psychological therapy is a tool that can be used to aid improving the quality of life for these patients. That piece can include both cognitive behavioral therapy, but also pain education with pain neuroscience education. Often these patients improve with either placebo or control medications, which is kind of interesting to think about. So, this is something that we can always counsel our clients and patients on, that this will likely get better if we can focus on primarily the physical activity piece. Now, there's certain additional treatments when we look at the chronic low back pain side, and I'll explore those a little bit more. Specifically on the chronic low back pain side, utilizing things like oral NSAIDs has been shown to be relatively effective. Spinal manipulation, which could be performed either by a physiotherapist, a chiropractor, certain physiatrists, and other kind of trained personnel, including osteopaths. Tricyclic antidepressants have also been shown to have clear evidence of benefit. These include medications like amitriptyline or nortriptyline. SNRIs, or selective norepinephrine reuptake inhibitors, serotonin norepinephrine reuptake inhibitors have also been shown to be effective. What's interesting is we're not certain about the benefit of things like acupuncture or rubefacient. I will say here the guidelines conflict with some of the evidence that has been presented, and we'll talk a little bit more of that nuance in a short while. Certainly evidence that shows there's no clear benefit includes utilizing epidural corticosteroids for chronic low back pain, and harms that exceed benefits. And this is kind of an interesting one to think about, especially with the uptick of cannabinoid utilization. So opioids certainly have evidence of harms along with cannabinoids. Again, there is nuance in this decision making, and we will talk a little bit about that kind of near the end, especially as I explore the TOPS guidelines that also have come out that may not fit exactly with the recommendations here. Again, on the neuropathic pain guidelines, the first recommended treatment here continues to be gabapentinoids, often the first shelf treatment that most family physicians will reach for when patients are describing these issues. SNRIs and finally rubefacient again have quite some good quality evidence. In this situation, TCAs, cannabinoids, and topical nitrates tend to have unclear benefits. And finally, no evidence of with evidence of no benefit continue to be acupuncture, topical ketamine, amitriptyline, doxepin, or combination therapies, which are quite expensive. And finally, harms include medications like opioids, topiramate, oxcarbazepine. Now, the guideline authors here very clearly identified that the quality of evidence here is poor, and these are really based on their recommendations. And certainly, pain management for these patients needs to be very much individualized. The evidence here obviously may not be the right way to help make patient decisions. A lot of this should be focused on shared decision making. Certainly, the ones in the red box or the treatments in the red box should be considered with a lot of conversation and with the patient, and of course recognizing that there may be harm here and that we're trying to help make quality of life better. In that setting, let's go delve a little bit into the low back pain medication management here. Again, oral NSAIDs, the recommendations to consider round-the-clock dosing, and here naproxen is a nice agent because it is dosed twice daily. The recommendations to avoid diclofenac for increased risk of adverse events. Obviously, consider adding a PPI to your regimen. Consider starting patients on Celebrex. This is a really great drug to be able to utilize long term. Of course, there are concerns around cardiac issues, so choose your patients wisely. Again, with SNRIs, duloxetine is the only well understood medication on this side, so that would be the first line that I would consider here. Its risk ratios are 1.25 with a tight confidence interval. Discontinuation is extremely problematic, so taper should be extremely slow and should be done ideally with the help of your pharmacist over even 4 to 6 weeks. TCAs, again, something to avoid in the elderly and people with QT prolongation issues, but certainly something that can be considered. I'll go through a wonderful tool in a few seconds that helps you decide what may be the right thing for your patients that they have actually developed through these guidelines. So on the neuropathic pain medication side, which gabapentin do you pick? There's only really two. There's gabapentin and pregabalin. The evidence sits to be a little bit more in favor of gabapentin with a risk reduction of about 1.58 for pregabalin. That said, if you wanted to convert or wanted to go from one to the other because it's not well tolerated, the easy ratio to remember here is that it's 6 to 1. Consider starting at nighttime because of the side effects related to these medications, including sedation, and often you should be titrating it upwards on a weekly basis. SNRIs, again, duloxetine and venlafaxine here are the best studied. The ratio of about 1.45. And finally, rubefacins, which include capsaicin 0.75, again, is the best studied, risk ratio of about 1.4. That said, this is the only formulation that we have available in Canada, and so something to be cautious of, because the evidence does look at stronger stuff that is available in the US. Now, I'm just going to take a big break. I know I'd said, these guidelines don't always fit with what the TOPS guidelines recommend for chronic low back pain. These were done more kind of in a Canada-wide setting. That said, where they do meet is really consistent and continues to be very consistent in the literature, which is that active rehabilitation and focusing on a self-management program is actually quite an effective tool in helping manage patients. Certainly other tools that have positive evidence include massage therapy. In this setting, as per the TOPS guidelines, really acupuncture is included that has positive evidence. Acetaminophen and NSAIDs, muscle relaxants such as cyclobenzaprine is a useful tool. TCAs and SNRIs, which are within the peer guidelines. Herbal medications, and these include things like devil's claw, wood spider. These are things that you can consider, but certainly is well out of my area of expertise and maybe best looked at by a complementary care provider such as a naturopath may be able to provide some good guidance around that. And finally, the biggest thing that we look at is multidisciplinary treatment programs, which are hard to access, but hopefully we'll talk a little bit about how you can kind of create or almost construct a multidisciplinary care team around you in the community. Certainly there's evidence here for interventional management, which I'll go to in the next couple of slides here. Negative evidence for initiating SSRIs, and certainly negative evidence for motorized traction, prolotherapy as a sole intervention, and utilizing TENS machine, again, as a sole intervention. But often, as I talked to at the beginning, these problems are much more complicated than just low back pain. Often patients have a spectrum of disease, and TENS is very useful in other aspects of diseases that are very related to low back pain. I just wanted to quickly go through or walk through what the CTOP tool looks like. This is available at www.pain-calculator.com. We'll put links in the actual recording. And it's a fantastic tool. It's developed in Canada, so really speaks to our patient population and looks at data from Canada. You can select a pain calculator with your patient at the bedside. Identify the treatment that you're going to look at with them. So say in this setting, we pick for low back pain, someone having, oral NSAID therapy. So we can click through that and we can really talk to them and say, if I prescribe this for you or we get started on this treatment, there's a 58% chance that you'll improve with treatment or with control. So really some sort of an intervention here may actually help you quite a bit. There's about a 40% or 42% chance that you won't have any improvement. The risk of you having at least one adverse event or a reaction to this is about 35%, so relatively high, but not many of these are life-threatening or life-changing, given that most people will continue it on. Only about 3% of folks will withdraw this medication. So this is a fantastic tool to utilize at the bedside, so you can identify with patients what interventions may be really quite helpful. In general, when we talk about improvement, we talk about at least a 30% reduction in pain. So that's how you can counsel your clients on what to expect. Now, again, the major considerations around those guidelines, like I talked to was, this needs to be individualized. The guidelines speak to a starting point, but certainly you may have to go well beyond that starting point. So you should really be focusing on functional improvement rather than pain management. You should initiate, titrate, and taper one medication at a time. Try not to add on more. Consider stopping pharmacologic treatments if they don't work for 8 to 12 weeks. If it's not working, it's not working. Sometimes it's also a useful moment for patients to understand, maybe as I'm stopping this medication, that this was actually helping me and helping. And finally, chronic low back pain is rarely discrete. It doesn't really fit one pattern like I unfortunately started to prescribe by. And that's where, the overall and the overarching recommendations are that the focus should not be on necessarily identifying the exact cause or the problem, but really also that the treatment all kind of converges on the idea of functional rehabilitation. But, there's really an opportunity here to talk a little bit about something related to interventional management, which is something that I often focus on in my practice. And we have a unique advantage in Alberta. Having trained in Ontario, we don't, in Ontario, there really is no access to interventional management to the scale that it is available in Alberta. And certainly the quality of that interventional management is actually quite good, with highly skilled specialists available in the community at a relatively with a relatively short wait time. So how do you actually, decide if your patients with low back pain may benefit from interventional management? And how do you decide what to tick off on that box? Because I know what it's like you're in your community office or your setting, and you have no idea with the form that comes to your, as to what you're supposed to tick off. So hopefully I'll go through some of that and give you some guidance on that. So first things first, how do you decide that your patient or your client is a candidate or someone that would be that would benefit from this? Number one, they should have trialed conservative management options for at least 3 months. You should be thinking this as a next step, not a first step. And it's really important to think of that. Shared decision making should be, again, utilized here. The client or the patient should understand this is a bridge to functional rehabilitation. This is not going to reverse everything, but this is really a way for you to be involved with ongoing management of your chronic low back pain. Ensuring that diffuse pain syndromes are also well controlled. If they have a history of things like fibromyalgia, these are certainly not certainly interventions that will help. Often they will cause pain flares and may actually worsen their connection with you as the therapeutic provider. And finally, recognize that just like you may have started, say, with medication management or specific exercise-based therapy, that these are diagnostic and therapeutic in nature. You start somewhere and you may have to change plans, and this may take time. So moving on, the only star I have for that 3-month mark is that there is one patient group that you can always consider, if they to have an earlier intervention, which is if they have a subacute disc herniation that you've identified in your office. And these are patients that may benefit from epidural steroid injections early. But let's look at the form that you have to unfortunately contend with in your offices. So on the left side of the screen here is the form. And, frankly, a lot of this is just gobbledygook for most folks. And when you kind of even drill down to the image-guided procedures, which are here on the right side of the screen, and say, oh, geez, I have no idea what some of these interventions are, or what they might imply in terms of how my patient might benefit. And that's really where I'm hoping to give you some guidance around that. So let's start off with the top of their image-guided procedures that they perform for you, which is facet joint injections. These are extremely commonly prescribed in Alberta and often can be a useful tool. They're indicated for primarily folks who have back-dominant low back pain, so they describe primarily a back component of their pain. They describe it as aching, sore, they're worse with lateral flexion, and typically does not extend well below the knee. They can have referral patterns into both the lower back, the groin area, the gluteal area, the lateral thigh or the posterior thigh area. What your clients or patients should expect is that they should have almost short-lived immediate relief, and may take about 1 to 2 weeks for the effect of steroids that are often injected along with the facet, with the local anesthetic. The expectation is that this should last for 3 to 4 months. And the thought process here is that in that 3 to 4 months with reduced pain, you're able to be more involved and more engaged with an exercise-based program. Even if they have short-lived relief, this is an important diagnostic tool, and certainly doesn't necessarily mean that this, that we have nothing else to offer. And hopefully I'll go into that in a few seconds here. So how do you decide, well, which level should I be ticking off on that box when it comes to low back pain? So typically, when it's low back pain, it affects primarily the sacroiliac joint, which I think of almost as a facet joint. It often will affect the L5, S1 levels, the L4, 5 joints as well. Physical exam, unfortunately, is an extremely poor predictor of outcomes. However, maneuvers such as lateral flexion can be useful. And that's where you have to understand that doing these procedures is just like actually diagnosing what the problem is. And utilizing radiographic tools such as SPECT scanning, there's moderate evidence for that, but things like MRI or CT scanning is not required pre-procedurally, and in fact, there's no clear evidence that improves the outcome of this intervention. And so, that said, I appreciate that not all of you will have access to this immediately in your office. So decision making may take a bit of time. And this is what your patient will experience when they are in the radiology suite, or say, at a pain center getting this procedure done. So they'll be under the X-ray machine, and often, the X-ray will identify the 𝐒𝐂𝐂𝐑𝐈𝐁 joint, which is kind of right here or over here, if you could see that on your screen, and a needle is advanced into that space, and the medication is administered. Now, I said sometimes this works for a brief amount of time, and patients say, well, this thing didn't work for me at all. What do you do? There are next steps, and typically the process of treating facetogenic back pain really is a bit more complex than just clicking off a facet joint injection. The patient goes there for the rest of their life to have this intervention, which could have significant side effects related to steroid. So the hope, firstly, is that they get a facet joint injection that's effective for, say, 3 to 4 months. But moving on, they can actually go on to have something called a medial branch blockade, which is the actual innervation to the direct facet joint. And that pain relief lasts only for hours or days. And so people say, well, wait a second, why do I want that done at all? And really, this is a test process that allows you to determine how should we be proceeding with the more involved next step, which would be something called radiofrequency ablation. And the benefit of doing that is that it lasts for 6 to maybe even up to 18 months, which is pretty meaningful, and often involves not providing the patient with ongoing steroid medication through their back, and limits every 3-month appointments and all this kind of stuff. So how does that work? So radiofrequency medial branch blocks, like I said, it innervates kind of the facet joint. And as you can see on this kind of brief animation, the way we do this under X-ray, you identify the site and you capture the nerves as they come off the part of the spinal cord, which are over here. So that's the nerve you tend to kind of burn away when you're doing that procedure. Typically, we should expect immediate relief. So as you're counseling your patients, they'll say, oh yeah, now, as soon as you have this procedure, if we're right, you should be getting off that, you should be getting up and out of that area with almost no pain. It should feel amazing. And at least 50 to 70% pain relief is expected until, and we would go on to then proceed to something called a radiofrequency neurotomy or an ablation procedure. This procedure expects you to have at least a 2-week recovery period, because the implication is that that needle is placed again on that same side of the nerve, and we actually apply 80 degrees Celsius, extremely high heat, to the tip of that needle to then burn that nerve and basically physically ligate that nerve to hopefully stop that signal from pain from the facet joint getting to the brain. The hope again is to provide ongoing relief, and this can be repeated as needed based on if your patient's or client's pain comes back again. Now, when you fill out the form, what should you be actually filling out? So first steps first, if you're trying to determine if this is the problem, facet joint injection is a very reasonable starting point. Followed by that, if you've been pretty successful and they come back to you in 3 to 4 months and say, oh, that worked great for me, I felt great, but it's coming back, I gotta do something about this. The next step here may not be to just send them back for the exact same procedure, but really to send them back for a medial branch block for probable neurotomy. And then you should identify the exact same levels, and hopefully that means that this is a 1 yearly or 1.5 yearly, or you do this once and in fact they get working on their physical function, and they never have to come see again for that same issue. This could also include the 𝐒𝐂𝐂𝐑𝐈𝐁 joint. So don't forget, the 𝐒𝐂𝐂𝐑𝐈𝐁 joint is essentially one big facet joint. And you could certainly do the same sort of process with the SI joint, with a facet joint injection of the 𝐒𝐂𝐂𝐑𝐈𝐁 joint, followed by a lateral branch block with the RF ablation, which is exactly what we described. So that's how you would address that. The next big thing you can often click off on the form includes utilizing epidural steroids. Typically, these are indicated for discogenic back pain or folks who have radicular pain. So this pattern 1 or pattern 3 of pain that patients describe. Often they have a history of X-ray imaging loss of disc height. And really what I counsel patients on is the idea that they would have probably a 50% chance of improvement, and that the improvement won't happen immediately. It often will take 1 to 2 weeks after the procedure, and hopefully should last 2 to 4 months after the procedure. The expectation is, again, what you click off here is really the transforaminal epidural steroid injection, rather than clicking off the intralaminar. I know it's a little bit tricky because typically they let you, it says right here, lumbar epidural steroid injection. You often want to check that off, but that's not often the choice that you should be sticking to here. And they want to kind of demonstrate why. So when it comes to, say, a disc-related disease, so this is the difference of what those two checkboxes mean. This is the checkbox that I'm telling you to think about checking off, and this is what the checkbox, this is right here with the transforaminal, and this is what I think the checkbox, the first checkbox is telling you to do. You can imagine, this is a spine in axial view. The moment you have a disc bulge or some sort of a slip disc, say, it often presents itself kind of like that. It pushes onto the side of the nerve. And you can see it comes from the front to the back. Injecting medication in the back typically should have less efficacy based on that. And that's where the thought is really, and the nuance is really that maybe if we inject it from a different side, the medication and the steroid will really get to the area where the nerve is affected. The potential space in the epidural side over here can be quite large. And in fact, the medication could never get to where the site that's affected is, because it is typically under compression. So you do have to get quite close to the problem here. So, certainly something to think about with epidural steroid injection. It can be very effective in patients who have radicular pain, so pain going down their legs, or discogenic back pain. So again, those are decision-making points that you can use on the form here, and I would really encourage you guys to think about that. Finally, let's talk quickly about surgical management. The biggest reasons for sending off to a surgeon or asking for surgical assessment are really if there's any red flags. This would necessitate urgent assessment, progressive motor dysfunction that you're seeing in your office, and that they've been continued to be refractory to management. That said, just to give you context of what we do in Alberta or in Southern Alberta here, we over the last year or so, in 2020 to 2021, I know these are COVID numbers, but something to think about, we performed about 1,300 thoracolumbar elective procedures. So a lot of spine surgery does get done. So even though you send off that, that form into the abyss for a referral to spine management or spine surgeon, they certainly see your patients. It's just they have a million referrals, which was why it takes so long to sometimes see them. Certainly emergencies get dealt with much more rapidly. That said, the incidence of postoperative pain, despite having surgery, is reported in the literature to be about 20%, extremely high. And there's really good quality evidence. The first one is really by this large Cochrane meta-analysis that identifies that surgical treatment for lumbar stenosis is really non-inferior to non-surgical treatment. And certainly rehabilitation is just as good of a tool as surgery sometimes can be for patients. In the same way it is for what we describe as sciatica, and conservative care is really quite effective. So I know some clients will be asking continuously for, well, I want an operation. It's really important that you can engage folks in talking about the fact that surgery may not actually help. And in fact, that really good evidence suggests that conservative management is just as good. So really getting back to those key pearls that we talked about, and I'm cognizant of your lunchtime, is that, low back conditions may not be related to the extent of anatomical issues. That's where your clinical judgment really matters. And this entire process is a shared process between you and your client, and something that is iterative and will take time to manage. Trust your clinical picture, not the imaging that you have. Rarely is it life or limb threatening, but certainly is quality of life impairing. And so it's an important problem to treat. There's multiple pain generators, so you may treat 40 or 50% by approaching it one way. That doesn't mean you can't do it the other way as well. You should be continuing to track function, not pain, and that functional-based rehab really is the cornerstone of management for these folks, with things like medications and interventional management really aiding patients to get to that bit. And finally, surgery can be indicated, but it is rarely indicated, and in the functional rehab is really an effective tool. And I'm going to briefly touch on the resources, and certainly this will part of this, including some of the findings, will be shared on YouTube along with some of the links. On the AHS side, you can certainly utilize the primary care networks that you have access to with chronic pain management programs. There's quite a few in Calgary, Edmonton zone that certainly have this. It is a bit more challenging in some of the less urban areas of Alberta. That said, Alberta Healthy Living is more accessible, more widespread, and will often have a chronic pain management and self-management programs, again, which have excellent quality evidence to help. Pain programs that are available in the country, in the province, are primarily in Edmonton, Calgary, and Medicine Hat. There is also another pain management facility in Camrose that are AHS funded. These are referral sites and often will have other tools that can help you manage patients within their medical home. There's a rehab advice line that is run by AHS. If you are struggling with what rehab advice to give for a patient, you can always pick up the phone and get advice from a rehab professional. Certainly, the Chronic Pain Center in Calgary has an MD to MD consultation. You can pick, contact with one of our physicians and hopefully identify tools that you can utilize in the community. There's a low back pain assessment pathway that you can utilize that's been developed. It was published in November of 2022. It has great tools from a rehab perspective and also ways to identify where should your patient be going. I'll post a link on that with the YouTube video that we'll publish eventually, along with that pain calculator, which we stepped through. In the community, and this is really where we have some fantastic tools available in Alberta, which is, your community physiotherapy and occupational therapy sites. Engaging with those providers is a really phenomenal way to develop a comprehensive program within the patient's home. Counseling and psychology, again, can be available. Often, unfortunately, it is out of pocket, but the Alberta Healthy Living Program can provide some support there. And many community specialty providers, and this is where really, I talk about the idea of having the Alberta advantage, at least relative to Ontario, where I trained, where we did not have as much access to sports medicine and clinics in sports medicine, physiatry clinics, and radiology clinics that can often actually provide you with those interventions that are so easy for you to get relative to what is available sometimes in the rest of the country. So definitely those are major tools available. And I know I've just overreached my time, so I've opened the conversation to any questions. Thank you.
Great. Thanks so much, Ameya, for that awesome presentation. Lots of good review and some new information, I'm sure, for folks in there. Thanks so much for that. There's so much to talk about on this topic. Most of us spend most of our careers working on it. So some great questions are coming in, and thank you for those. I've got some great help from two of my colleagues in the background putting those together. So Ameya, one of the questions that's come in that's, I think, very relevant, especially in Alberta, is there a concern that this level of intervention further reinforces the biomedical approach and the biomedical model that we know doesn't really work well, sadly, and when chronic pain is actually a lot more complex? So, perhaps we should be focusing more on things like movement and sleep and mental health. Could you comment on that?
100%. I certainly agree with you in terms of encouragement of that biomedical model. I think when it comes to accessing some of those other services, we're in a position where resources are limited in terms of what is covered by AHS, and that's really the major crux of the issue. That said, there's a phenomenal amount of evidence that suggests that self-management programs are very effective. And a lot of those self-management programs can be available to patients online. One of the most common ones that we think about are, going to tamethebeast.org. It's a fantastic tool that identifies pain neuroscience and the management of pain neuroscience, how pain neuroscience can help. That part is a hard pill to swallow sometimes for patients, and in a very kind of funny way. It's a tool that takes a lot of effort, both on the provider side and the patient side. And I appreciate that community providers are not able to fill their time, or not able to spend that time necessarily with their patients. That said, there are some bright lights on the horizon to be thinking of. So I think the Alberta Pain Strategy is coming out with a lot of tools that allows a lot of the self-management piece to be addressed within the patient home. I think this is going to be announced within the next little while around virtual chronic pain care, which will not kind of fit between that traditional primary, secondary, tertiary, quaternary care, but more so will sit right next to all of those pieces and really speak to access from all levels of care, so that you can utilize interventional management, but in conjunction with that piece, like you identified, which is extremely important: sleep, mental health, improved physical therapy.
Absolutely. And really making, I liked what you said about creating your team in the community. Many of us work in those sort of settings, and it's more work than being under the same roof, but helps our patients most of all. Yeah, I know that's a great thought. Now, one of the pearls that you mentioned that one of our viewers had wanted to take on was this notion of tracking function. And is there anything particular that you like to track around function, or resources that you recommend for people to have a helpful, quick outcome measure of sorts, or even something relevant to the patient, so that we get away from this measuring of pain constantly?
Sure. I mean, there are tools available that are used in the that are used primarily in the literature, but also in maybe, say, chronic pain clinic settings, where you will often have more time to see a patient. That said, the BPI, or the brief pain inventory, has some excellent pieces in there that identify the ability for you to track function. And one way to include that within your practice could be that this patient fills it out every time they see you, and you can utilize that as a way to track their progress. There are much less granular tools that help you identify, at your initial consultation, if you felt that the patient said, I can't really swim anymore, that's something I enjoyed, and bringing that piece back. That's really related to the therapeutic relationship you have with the patient, and part of that is the conversation you have with them. Often tools and questionnaires, in some ways, are good in that they force us to rate something, but in some ways can be terrible, because it's often 0 to 10, a Likert scale, which cannot capture function as easily as saying, hey, did you last time, or the first time I spoke to you, you couldn't even do your groceries. What do you think now? Are you finding you're able to do your groceries, say, 50% of the time? So this is really a piece where the therapeutic relationship matters, and longitudinal relationships, which is what happens already with most folks in the community who manage low back pain. It's the only way we can understand what's going on with with your clients. That's what I would recommend.
Yeah, no, those are great thoughts, Ameya. Thanks. And someone was curious, and this comes up a lot on the prevention side. Can you comment on ideas or pearls, or even things in the literature on how we can better manage acute back pain in that sort of 4 to 6 week phase, to help prevent it from progressing to chronic? Because there's a window there.
It's a great question. Certainly, there is some quite good evidence for something not to do, which is bed rest. We constantly recommend bed rest is not recommended. That hurt is not necessarily connected to harm in that acute phase. That's one thing. Adding on other tools, such as engaging with functional rehabilitation at that stage, is extremely important and actually quite effective as an intervention. Utilizing medications in the short term, including opioids here, is not unreasonable, with a very kind of tight control on how many what your opiate prescribing is looking like. Recommendation around opioid management, especially from, say, the TOPS guidelines, is to utilize weak opioids, and certainly that would be the best tool. In terms of engaging in other activity, returning back to work as soon as possible is actually shown to be effective in minimizing or limiting the functional decline that can be associated with chronic back pain. That said, that doesn't necessarily mean, especially if you're managing a person whose job is lifting hundreds of pounds, it's not to say they should go back to that, but going back to some sort of meaningful work is actually a really important tool. With modified duties, it can actually help with the recovery piece. It reduces kind of that malingering or catastrophizing of pain that can occur in that awful 6 to 12 week mark. And there's excellent evidence to help with that. Like I said, the biggest thing here is to re-engage with the physical therapy side of things. recognizing that that hurt is not related to harm. Bed rest is really bad. Utilizing medications here is not unreasonable, including medications that we're typically averse to prescribing, such as opioids. Those would be the big things. On the interventional side, I would not recommend interventional management at all at this stage. However, the only kind of thing that may be effective is an epidural steroid injection if you believe that the patient has radicular pain, related to a slip disc or some sort of a disc herniation that was confirmed, say, with imaging.
Right. Yeah. Thanks. So that's a great thought. And I think we have time to squeak just one more little quick question. And although it's not a quick one, one person had a comment or had a question around the notion of placebo. And placebo has been shown to be effective in low back pain in the literature. And what are your thoughts on how we might be able to tap into that a little more productively as clinicians?
It's a great question. One of my colleagues was studying placebo, and really they pegged the effect of placebo to 30%. And coming from the chronic pain world, 30% improvement seems great. To me, that sounds like a win. So, if sugar pills can do that, well, what's the point of using, say, gabapentin? So it's certainly a complicated question to answer. I would say, tapping into placebo with your patients is really a tricky situation. I'm not necessarily the de facto expert on behavioral science here, but really here it is utilizing things that have very limited harm, but definitely possibilities of benefit. So things like acetaminophen may be a reasonable thing to think about as placebo, especially for your clients or patients to say, well, I don't take any pills, even if I don't have to. Even if I need to, like even if I have a bit of a headache, I'll go take a nap. That's where you might say, actually acetaminophen may be a really important tool here. The risk of harm is extremely low. There certainly is a risk, there's a benefit of possible placebo effect. And you certainly don't want to be in a position where you're not getting, you're not getting a nocebo effect, which is because you're not giving them anything, they're perceiving that their pain is getting worse. So that's kind of where I would stand on that. But it's an excellent question. Other tools that you can utilize that may include placebo effect, but may actually have evidence of therapeutic effect is things like hot and cold therapy, utilizing hot packs, cold packs. Again, the risk of harm is exceedingly low, and the possibility of benefit is at least 30% if the placebo side is to be believed.
Yeah, that's a great way to approach it. And we know too that if we can create a window for things to settle, then by default, people typically tend to do a little bit more on the function side, which is excellent. Yeah, great. Now I'm just noticing the time, and everyone probably wants to have a quick little breather before they get back to their clinical time. Ameya, I'd like to thank you so much for your time today and this great presentation, and for all the people out there for throwing in those great questions. Sorry we couldn't get to them all. Again, we could talk about this for days and days on end. And please keep an eye on the Pain Society of Alberta's website for our YouTube channel with the recording of this coming up and other presentations as well. And please keep an eye out for conferences and other upcoming events that we will be hosting. And Ameya, well, thank you so much for your time today. And I hope everybody has a great day out there.
My pleasure. Thank you, everyone.
Thanks so much.